Need to quickly do one legal thing as we move ahead here. And all this really says is, A, I have the qualifications and know what I'm talking about when it comes to the things that I'm going to say. And the second thing is, please don't use any of the numbers in this presentation or rely on them in any way. They're going to be appropriate and for the uses at hand, but don't rely on them for any business decision, anything like that. It's very simple. So we need to get that out of the way. To get into the study that we did, many of you are probably aware of the study that we did already. Talk about it a little bit. I just want to give you just a quick overview of myself and how I got involved with DPC. So about 5 years ago, and if you were in Julie's session, in the name of Josh Umber, I was at a Society of Actuaries meeting where Josh spoke. And up until that point, I had worked within the healthcare system as on the carrier side with Blue Cross Blue Shield for about 22 years. And I heard Josh's session. I just left and was getting ready to start my job here at Milliman. And I heard Josh speak, and I was immediately smitten, as it were. Not with Josh, but, and I apologize if you can hear the emergency vehicles in the back. Not smitten with Josh per se, but with the concept of DPC. And so at that point, I more or less became a wedding crasher. I started attending DPC conferences and started buying DPC doctors' drinks. And before you know it, they started talking to me. And that's literally what I did. I also spent a lot of time talking to DPC doctors that would talk to me. Because I had in mind that we would ultimately want to do a study. So ultimately, that was really it, how I got involved. We then applied for a grant through the Society of Actuaries, and that's how we did how we went about accomplishing our study. So again, if you Google my name and SOA and DPC, it'll come up. They're in a number of different places already. But the name of our study was Direct Primary Care, Evaluating a New Model of Delivery and Financing. And if you don't know anything about actuaries or about the Society of Actuaries, we do most of our work for insurance companies, but we also work for ACOs, hospitals, doctors, pretty much state governments, federal government. We do pretty much anything that touches healthcare. We are called upon to give a reliable, accurate, unbiased estimate of costs and risks. So that's what an actuary is. And the Society of Actuaries was the one who helped us to get this study going because they were very, very interested in it as well. So that's the name of the study. There's the author himself and a guy with a very complicated Polish name. And again, the Society of Actuaries was the sponsor. We used data from Union County, North Carolina. So that was the first data set that we could find that was large enough to do a study on. It had about 1,000 members in each of the DPC options and the traditional option. So it was about 50-50, so it provided a very good case study for us to do a study. We also got great cooperation from the TPA that helped with their claims. So we got all of the downstream data as well. So we were able to apply all of our fun actuarial tools, if there is such a thing, to this data. We had a lot of help along the way, and we worked with the American Academy of Family Physicians, who was very helpful on the survey portion of our study. We interviewed a lot of DPC docs as well. Some of you might be on the phone right now. Very headed to those very helpful and in-depth conversations. The DPC Coalition and the DPC, now I forgot Joe, Alliance, sorry, the Alliance. We're also very helpful. And significant shout out to Jay, who was extremely helpful in terms of coordinating the different interested parties in this study, keeping me informed, making me feel a part of the team. So I really appreciated his professionalism, and I consider Jay a friend as well. So there. So what did our study find? Again, I'll let you read the good executive summary that you could read in probably 10 minutes if you wanted to read that. But the key finding were that between the DPC group and the non-DPC group, gender and risk, which are important adjustments that actuaries like to do and they have to do to make it credible. We saw a statistically significant reduction in overall costs of about 13%. We also found a statistically significant reduction in emergency department visits of about 40%, which was not surprising when you consider the access component of DPC. That was a very positive finding as well. Found a reduction in inpatient admits, but it was not statistically significant. So in all fairness there, belief is that there was a real reduction, but again, statistically it didn't say that. It wasn't credible, so we had to note that in the study. Finally, we found an overall ROI, return on investment, for the employer of about 1.3%, which was it's not as big as the savings because you pay more to what they were paying in direct primary care. So again, this is not entirely unexpected. DPC does represent a higher investment in primary care than is done in a traditional environment. The one comment on our study is that in terms of, say, the 13%, we had some people who we had other people that weren't so happy with that. And I don't know, what is that? I guess the baby bear, I thought it was just about right. It to me that it was a reasonable result. It didn't, if I would have found a reduction in care of 80%, that clearly would have been a red flag. Cost increase, that would have been a red flag as well. So this felt to me about where, it felt to me to be a reasonable result. But welcome to research. Not everybody liked it. Now, and some people loved it. So, but in any case, I would urge you to read the study, at least read the executive summary if you don't have time. And then from there, now, what I'd like to do is I'd like to go to more of the path forward. Okay, so here's just an informal roadmap for this session that we'll try to get done in a relatively short amount of time. But I'll talk briefly economic dysfunctions. So what's wrong with healthcare? I think we all probably have a lot. Then we'll show how DPC directly addresses these. And then we're going to take concepts, the core concepts of DPC, and ask how we can extend that to certain other areas within healthcare. And then I do have some realistic, but they're hypothetical numbers to frame up the costs. And then we'll have some concluding thoughts and hopefully some time for Q&A. So let's get started. So what's wrong with healthcare? Well, this word cloud, maybe some of the words that you might come up with: waste, physician. We spend more per capita than pretty much any other country. There's all kinds of things wrong with our healthcare system right now. I don't think that that's a particularly controversial statement, given this crowd. However, these are symptoms, and what I want to do, talk about root causes. And when I talk about root causes, I'm going to come at it from an economic perspective, okay? And so there's other perspectives you could take. You could take a clinical perspective, or we're not going to take that. Here we're going to talk primarily about incentives, because that's what economics really is it's about incentives. We're not talking about attitudes or motives. We're not talking about people per se. And I want to be very clear that we're not making a criticism of people. We're talking about a system that we have that has certain incentives that people are responding to bring about some of the pernicious effects in our healthcare system. So first on that hit parade, probably a lot of electronic head nodding going on with fee-for-service. There's no doubt that fee-for-service, now keep in mind, we're not talking about fee-for-service when a patient goes and pays for a service. We're talking about the reimbursement to providers on a fee-for-service basis. Fee-for-service then, of course, means that you have to do coding for payment, which takes up an enormous amount of time. It introduces certain incentives to upcode, to code for volume, and there's things like that come just by having a, quote, fee-for-service system. There are times when fee-for-service is necessary, and we won't, for the most part, it's not a very good system for reimbursing in healthcare. It gets worse, though, when we introduce the second element, which is third party. And all we can really say at this point is that the combination of fee for service brings about, at that point, you have basically disconnected all back loops that would normally be associated with a healthy economic system. Things like supply, demand, real prices, transparency, quality. Most of the incentives to lower costs and to improve the product are at this point. You could probably spend an entire session talking about, you know, some of the combination of these two, but there's one more. And this is the one that's going to lead us into the rest of the conversation that we have here. And that is, my formatting is a little off there, didn't quite turn out, but that's supposed to say uninsurable expenses, meaning that health insurance policies cover a lot of expenses that are technically now uninsurable. All right. What does it mean to be insurable? Well, this is the concept. We'll talk about the reality here in just a second. What does it mean to be insurable? Well, for one, it means that the risk or the expense is low probability. Okay. And I have an asterisk there that also says it's typically assumed to be out of the control of the policyholder, right? Which makes sense on low probability risks. So in other words, if it's high probability, you can predict it and then you don't need it for it. Okay, so they should be low probability. Should be a significant loss as well. Catastrophic per se, but it has to be significant relative to the person's income and all right. And what actuaries like to call this is low frequency and are technically insurable risks. Now, the reality, of course, is that that's not what our major medical policies actually do. Our major medical policies are actually hybrid financial vehicles that cover both insurable risks, high frequency, low severity, sorry, other way around, low frequency severity, and uninsurable expenses. So they're combined. The insurable risks, of course, need financing, and they need insurance protection to keep people from losing their livelihoods. Uninsurable expenses, by contrast, need a way to pay for it only. Insurance risk there, so there's no real need for any financial protection. You just need a way to finance the care and then ultimately to deliver it, okay? So the similar treatment, I'm just going to read this, a similar treatment of the two fundamentally different types of costs, the insurable risks and the uninsurable expenses. This is what creates the market dysfunctions. Misaligned incentives, moral hazard. Moral hazard is just the inducement policy, okay? It's all kinds of moral hazard in there. When people are shielded from the costs, when providers know that people are shielded from the costs, it provides an opportunity to use the policy, increase utilization, which increases costs. Decoupling, the key here is to the extent that these two types of expenses, insurable and non-insurable, decoupled, we can reduce the dysfunctions in the healthcare system. Okay? Now, let's take a quick segue here to direct primary care, and then we'll come back to this. So I'm gonna list these tenets of direct primary care. We're not gonna go through them because you guys know them already. That's why we're here, right? But I would argue that the key, with the capital THE, key tenet includes these, but it's actually the concept of disintermediation, which I know I've heard many of you talk about this, but this is just the idea of removing the middle. In fact, disintermediation is built into the name. It's direct, right? So that's the key, is that middleman. And when you do that, direct primary care addresses all three sources of dysfunction. It disintermediates where appropriate, right? Which is disintermediate in the case of primary care. Doesn't pay fee for service, and it covers clearly uninsurable expenses that are foreseeable and affordable. Okay, so this is why direct primary care actually works, is because it creates a better marketplace. It addresses the key dysfunctions in our healthcare system. Oh, there's one more little tidbit there, addresses the root causes. So now when we go back to our concept here, we have to ask the question, well, where could an alternate financing model such as DPC, where could that concept be extended to? Okay, in primary care. It's occurring, it's successful, it's awesome. Do we want to disintermediate insurable risks? Absolutely not, right? There's no way you guys, most of you on this call are providers. You don't want to be in that business, right? You want to be in the business of delivering care. Obviously, then the question is, can we extend this to some of the other uninsurable expenses? And me and my team have spent some time thinking about this, done some work on it, some conceptual work as well as some actual work, and we're going to show you some of the things that we came up with here. So one of the things that we have here is that I call, I might be overselling it by construct here, but it's basically what I call the 85-15 construct. Okay, is if you stack ranked everybody from high to low in terms of their cost, from high down to the lowest in terms of their cost, and drew a line at the 85% of healthiest people, and then the 15% of the remaining 15% of the highest cost. What you would see is that at any given time, 85% of the people will have just basic healthcare needs, and these needs are largely treatable in a clinic or with generic drugs. Okay. Now, those 85% of people only constitute about 23% of the cost, because the other 15% of people are very, very expensive. But it doesn't change the fact that at any given time, most of the people just need basic health care. Okay. The services that they need are higher frequency and lower costs, and they're relatively predictable. Okay, which makes them great candidates, noted before, for alternative financing and delivery models. Looking at it slightly different, the lowest cost 85%, because they don't have category, really only need financing, as we noted before. % obviously need both a way to pay for it and protection. And just a quick caveat, it doesn't mean that the 85% of people don't need insurance. They do, because you can switch buckets at any time. It's important to note, people can switch over to the 15, and that's hence the need for insurance. The idea is, if we can tailor the care on the 85% to keep people from switching and improving the delivery, this is where the savings ultimately come. So let's take a look at the costs between the 85 and the 15. Now, if your eyes are glazing over because of numbers, I'll help you look at what you should be looking at here. So if you look at the 85 PMPM, we see that their monthly costs are about $140 a month. That's $1,700 a year. If you look at the highest 15%, their PMPM is about $3,000 per month. Okay, and this is by definition, right? This is how we drew the line. So if you look at the distribution, though, the professional cost and generic drugs, or drugs in general, about 84% of the lowest 85, that column there, of their cost. Most of their cost is professional costs, right? Office-based clinical costs, and then all the drugs that they take. By contrast, you can see that the highest 15 have a significant amount of their cost. Well, they have significant costs everywhere, but they have a significant inpatient and outpatient, right? These are typically higher cost insurable claims that are not, good candidates for alternate finance. Now, when we break down the 85% a little bit more, $142 here, and you can see it's about a 50-50 split. Specialty costs, so specialty physicians, endocrinologists and the like, and then PCPs, okay? Then you've got some additional outpatient other is mostly radiology. You've got ER, outpatient surgeries are next. Colonoscopy are usually done outpatient, but we've broken those out. Got physical therapy, occupational therapy, speech therapy. And then you've got some other costs down there that are fairly minor. As you can see, most of those costs are very good candidates. They're higher frequency, lower cost, and they have the ability to have alternate financing models put towards them. So this is, again, these are hypothetical numbers, but they're fairly representative in terms of how costs are distributed for a large percentage of the population. Now, to close it, or the idea section of this session, these are just are going already. These are some of the things that we've seen we know people are working on. They're not ubiquitous by any means, and there's some, I guess, maybe thought leadership here in terms of what might constitute a way that some of these non-insurable costs could be financed. The first, of course, is DPC. You all charge a membership fee. So you could think about an expanded membership fee where it additional services beyond what you currently do. We've also seen what I call bundled. DPC doctors go out. They look for partners where they can bundle services, get them arranged with another provider, say a hospital, with, I do not remember the gentleman's name, the DPC, but he went out and arranged for a colonoscopy package. Basically, it goes along with a colonoscopy with the local hospital. There's probably potential there to do that in other type of episodic care as well. What I call a high performance network, it's not really a network in the same sense that you think of a network. So, but really it's just a DPC doctor or an organization that helps DPC doctors do this, could contract with a set of preferred providers, particularly in specialty with a multi-group specialty group or others, where this is arranged on behalf of the DPC patient in a form of a network, but not, again, not in the same sense that we normally think of network. Sub-membership fees. So again, same sort of idea, potentially building in a certain amount of into the fee that is ultimately then paid to somebody else, such as imaging specialists. So instead of paying for those things, you know, I know there's a lot of arranged DPC doctors with labs. So a way to do that also is to just build a $1 per member per month, something like that, or $2 or something, whatever the cost ends up being. And then that just gets automatically paid to another provider on that risk of total volume. And the final, of course, is the expanding fee for service. So patients pay for anything that's under their deductible, but it could come from your office, and it could be arranged in some other way, but the patient continues to pay for service. All right, and with that, a couple of speed bumps on some of this. I would be remiss if I didn't do that. First of all, we need to. Jay is probably on the phone. He is very. I'm going to go in reverse order here. There are still on DPC memberships coupled with an HSA that you need to be aware of. Of course, nationalized healthcare in any form is a possibility, and potentially of free market solutions that we've been talking about here. The Care Act, of course, requires on all fully insured products to cover the 10 essential health benefits. So most of what we talked about today isn't really applicable at all in terms of a fully insured arrangement in the group market. It's really targeted at the small group, which is a growing market, which is good. Small group self-insured markets. My contact information is down there. If you have any more detailed questions that we don't get to, please feel free to send me an email.